a tremendous delight and honor. And I think I'm a little, not little, I'm very fortunate to have some of the best friends in the world. So Akhil has been so sweet. Akhil, thank you for that very warm introduction. I think my only introduction is that I am your friend. And that's the only introduction that I think is of importance. It's also a pleasure to see my dear friend Vikram there.
Hello,
Uh,
sir.
Hi, Vikram, and all of you. Sorry I'm late, but I was just coming back from the COVID ward, so थोड़ा late हो जाता है. But then I think I'm here, and thank you all for waiting. Should I start now my
Please
session?
share the screen, sir.
Thank you. I'm going to try to do screen share.
So you can make it full screen.
Yeah, yep. My computer has a mind of its own, you know.
No,
All right.
fine, sir.
Fine.
Okay, so it does. It takes its time. Okay, great. So, um, so the plan was to talk mainly about long COVID, but let me start with what is. I'm sure you've had 1 million talks on COVID. This is the germ that has wreaked havoc in the world. What you see here are these spikes. What you see here is a picture of the spike protein. Uh, the reason that this virus is called a coronavirus is because if you look at the spike protein sticking on the surface of the COVID virus, then these spike protein give the figure of a sun with the radiation, and that's the corona of the sun, and that's the name. The spike protein is the danger part. Um, and the reason I bring this slide is because present and future treatments are going to be directed at the spike protein. The spike protein joins or attaches to the ACE receptor. It is co-attachment to the TMPRSS2 receptor, and these two receptors play an important role in the internalization of the virus. Now, the reason why we are scared of the Delta virus and the reason why the whole world is very worried is this spike protein recently mutated in such a way that it got even more infectious by getting more attached to the ACE receptor. One of the reasons they said the kids are spared is kids have less of the TMPRSS2 receptor, and that may be the reason why the children are a little more spared. And that is why I think as we deal with the COVID, we need to know a lot about the spike protein. We got to get to know it very well. This gets internalized. All treatments today are being directed to block the ACE receptor binding to the spike protein. Not all, well, all the new ones and the antibodies. And that's why I brought this picture. Now, of all the viruses, this is probably the only virus, and it surprises me. Every other virus is specific to the organ. An encephalitis virus will go only to the brain. The HIV virus will only go to the cells, blood cells. The conjunctivitis virus is in the eye, but this virus, hepatitis is only in the liver, but this virus affects every organ. And it is important to know that because time and time again, you and I, as clinicians, will meet patients who will ask us, yeah, today, doctor, but I don't have fever, I have only a cough. Is this a symptom of COVID? I said, anything can be a symptom of COVID. The fact that you're living in 2021 in India is a symptom of COVID. So you can start with the most important being the lungs. You're all aware, I'm not going to go into the details of this, but just to give you an overview that the clots can be arterial, they can be venous, and above all, it can be a small vessel vasculitis. In fact, there are a lot of data that shows that the small vessel vasculitis affects the brain. In even asymptomatic people that died of other causes, autopsy showed that many of these people had asymptomatic vasculitis, which has resulted in, at that moment, subclinical, but later on I'll talk about long COVID. So that small vessel vasculitis may be the cause of long COVID. Conjunctivitis, nasal symptoms, and nasal symptoms can be long lasting. Uh, Pancreatitis, every one of my pancreatitis, I think only two survived, all others died. Gut diarrhea, everybody knows this. So this is an atrocious virus that survives in so many uh, organs that doesn't happen in any other virus. Well, you're all aware of the treatment paradigm. The initial part is directed towards the viral phase. The latter part is towards the inflammatory phase. And let me quickly run through this because I know you've had many discussions, but I think it's important to remember that you don't need to give all medicines at the same time. So the early phase medications are essentially antivirals, and I have been aggressively using antivirals right from as soon as I got them, and the reason is that even if they don't reach statistical significance, even if I can stop the growth of the virus by 5%, I can prevent probably 5% the complications of acute and then subacute and then long COVID. So I'm a firm believer, and I believe that after this favipiravir, remdesivir, next month, maybe next week, we're going to get molnupiravir. So that's the one I'm looking forward to. Very exciting. I've been aggressively using monoclonal antibodies, and anybody who wants to talk about that can. I'm happy to discuss that. But I think it has a role to play. I'll just give you an example. I have now a 70-year-old male diabetic, creatinine is high, so I cannot use remdesivir. He also has high uric acid, so I cannot use favipiravir. So monoclonal antibodies, he's got bad lungs. His IL-6 is 200. His CRP is in the triple digits. So I think monoclonal antibodies are worth the money